assessments in children. How does that differ from sitting down in front of a patient, sitting at bedside, calling them by name, going through a review of the systems, making sure that they're comfortable in developing a report to where we can determine sensitive information. How does that differ from getting a history from an infant or a child or a pediatric patient up to about maybe 10 years old? How do you think assessment's different?
They communicate differently, obviously.
Sure. What about if you come in through the room and you've got a white jacket on, and the kids start screaming immediately? You know, how do you conduct an interview? So one of the things that we do is we're all wearing the same color scrubs, right? So it's different than the nurses. Hopefully they haven't associated someone that comes in to draw a lab with a lab coat on that they're going to cause pain, and they're not going to start screaming. But what did you say about parents?
That they would know more of the history of the child.
Yeah, so we have to involve the parents, and sometimes even the maternal history. If it's a newborn, if it's a newborn patient, we have to involve the maternal history, and if the mother was exposed to anything. So using maternal history, using neonatal, prenatal history, any complications or problems could impact on the future health of the child. So maternal history, prenatal history of the child. One of the things that we want to know specifically is how many previous pregnancies the mom had. That's important. It's important, meaningful, relevant information. If this is like the Duggars, if this is infant number 19, you start thinking 19 pregnancies. That's got to be rough.
She loves it.
That
She's
girl,
got to.
She loves it.
she's a trooper.
Uterus is well used.
So previous pregnancies, the general health of the mother, that influences the health of the child. A newborn is taking everything out of the mom to get the nutrients they need, the development. I mean, that they're growing from cells, essentially the fastest that they'll ever grow again in their whole entire life while they're in utero. So the development is particularly tied to the health of the mother, and so you kind of want to ascertain how the mother was doing, how the pregnancy went, how many weeks gestation this infant was born at. Does everybody know that 40 weeks is average? 40 weeks is normal gestation. Kids can be born as early as 36 or even 30, bless you, dude. 36 or 32 weeks and still be, normal, I guess. They can survive fairly well, 36 down to 34. 32's kind of cutting a corner. That's 6 weeks early. That's a month and a half early. So at that point, they're going to need. They're going to need help. 36 weeks, they're probably right on the edge of needing help versus probably going to be fine. But the last thing to develop, I'm sure you know, are the lungs. So a baby's biggest hurdle being born earlier than 40 weeks is lung development. So go ahead, Hannah.
What was it that used to happen to babies before, I can't remember, when their lungs didn't open all the way, they would put them on straight oxygen or something like that would cause mental retardation for them?
Retinopathy. So if they don't open all the way up, they have low PO2s. They're hypoxemic, and so that hypoxemia used to be treated with oxygen, and oxygen at a high FiO2 produced a high PO2, and the high PO2 caused retinopathy of prematurity, or what we used to call retrolental fibroplasia. So it caused scarring of their optic nerve on their eyes, and they were blinded. They were blinded because of oxygen. So some mothers have questions about if you're giving their baby oxygen, if it's going to cause blindness, and you can explain to them it's not the FiO2 that causes blindness, it's the indiscriminate use of oxygen that causes retinopathy.
Was there something else that it would do, though?
Not specifically. It causes nitrogen washout and microatelectasis,
Okay.
but oxygen's not a good, it's a drug, and it's not necessarily a good thing to take in doses, over, creating a PO2 over 100. So we have to be judicious in the way we administer oxygen. So, general health of the mother, gestational age, 36 weeks, probably the edge of normal. Anything less than that, we start to think that the baby's going to need extra help. Things in the assessment might include the quality of the amniotic fluid. If it's clear, if it's murky, if there's any foul smelling to smell to the amniotic fluid, it could mean infections, and then we have to be ready to resuscitate a baby that's born under those conditions. Another one, the first bowel movement inside of the uterus is called meconium. Have you heard of that before? Meconium. So meconium is a black, tarry kind of a stool, and it's very thick, it's very tenacious, it's sticky, and so if there's meconium inside of the amniotic fluid and a baby's born, particularly after 40 weeks gestation, what they can do is, on that first breath, suck the meconium into their mouth. And so if meconium gets in there, it sticks to the side of their airway, it gets into their trachea, and we have to have, and in fact most rural hospitals now have respiratory therapists on all the deliveries, every delivery, especially if it's a post-term delivery. They'll send a respiratory therapist and a nurse and probably a physician, the physician that's delivering the baby, if they know it's after 40 weeks. But what we'll do is we'll use a laryngoscope, we'll open up the airway, look at the vocal cords and the arytenoid cartilages, put a tube into the airway, and then use the endotracheal tube with a suction catheter like you saw. Use the endotracheal tube and suction, put saline down into the tube and then suction the endotracheal tube back out. So we would usually, you might have seen an endotracheal tube for an infant. It's about a 3.0 millimeter tube. We'll put a suction catheter inside of the endotracheal tube and then use that as a suction catheter. But it's very, very small. It can't get a lot of meconium. So they'll sometimes use the tube itself as a suction catheter. Put the tube down, put saline into the tube, and then apply suction to there's a special device that applies suction to the endotracheal tube, and then you pull that out with the meconium, and then you re-intubate again and suction meconium out, and intubate again and suction meconium out, and intubate again and suction meconium out. I've done that as many as 14 times for one infant. So you're trying to get all the meconium out of the airway so that when they breathe in, it doesn't get stuck. What can happen with meconium aspiration is pneumothorax, because it sticks against the side of the wall, the baby breathes in, and then they can't breathe it out past the meconium, and then it creates something called a ball valve effect. And the ball valve gets further and further and further and further in to where you can't suction it out, and then they blow a pneumo past that meconium plug. So I've intubated a baby 14 times with a endotracheal tube to try to clean out all the meconium, so that we were comfortable in letting them breathe on their own without that meconium in there. So meconium aspiration is a big complication with post-term infants. And so we have to know what the gestational age was and whether or not that presents the possibility of complication, right? So meconium generally comes from stress inside the mom. So if mom's under a lot of stress, the nice thing is that stress will cause the development of surfactant. Normal surfactant comes about 36 weeks. So normal pathways, normal mature pathways for surfactant. Now, you know, anatomically you have the alveolar surface, those are alveolar type 1 cells. Then you have alveolar type 2 cells, which is the surfactant. Then you have alveolar type 3 cells, which are macrophages in there. So single cell thick structures, this type 2 cells start producing normal surfactant to reduce surface tension about 36 weeks gestation. So then you've got normal pathways for surfactant. prior to that, surfactant isn't developed and the alveoli become stiff and they won't expand. It takes more pressure to open them up because with surfactant it reduces surface tension and that allows you to open the alveoli with lower and lower pressures. Make sense?
Is that why some babies can be born before 40 weeks and be okay if the mom is kind
Yes.
of under some stress?
Moms under stress, they develop normal pathways for surfactant production earlier than 36 weeks. So if you're born 36 weeks, you're out on the edge. If you're born 35 weeks, 34 weeks, you don't have normal surfactant production. Does anybody know what test they use to measure surfactant production? It's called the PG test, or it's phosphatidylcholine is what it is. So it's a PG of more than 2.5 or something. You'll learn those when you get into clinical. But that's what they're looking at. They're looking at normal production of surfactant at after 36 weeks. So
My mom's friend, her husband's 6'6", and she's only 4'9".
really,
So the babies had to be induced earlier,
wow.
and they were worried that the lumps weren't going to surface.
Yes. Did
But
they give mom steroids?
They were gonna, but when they did, I guess that PG
The
test,
PG.
they were fine. So
Yeah. Excellent. So they can test it to see if it's a normal surfactant producing pathway. The other test is called an LS ratio. Have you heard of that before? LS ratio is lecithin to sphingomyelin. Just a FYI. That's not on any test or anything. But a lecithin to sphingomyelin ratio.
You spell that for me.
Yeah, lecithin. Go ahead, dear. Oh, you're okay. So it's looking to see if it's normal. So it's important to know, I guess, getting back to assessment, it's important to know how many weeks the mom's along. And they'll sometimes do femur tests. They'll measure the femur, they'll measure the head circumference in utero to see, to estimate about how far they are along. And sometimes their dates are often off, right? By a week or two here or there, you never really quite know. So they're trying to get better at femur length and circumference of the head and things like that to tell how many weeks a baby is. So they can prepare and be ready at any hospital. You know, it makes a difference if you're at a regional hospital or a community hospital versus a big medical center, what resources they have available to them. So it's just important for therapists to know, how many weeks is this infant, this newborn that we're waiting for, how many weeks gestation is it, so I know what to prepare for. If I'm going to have to intubate and put them on a ventilator, I want to know if they're 34, 35, or 36 weeks, because it makes a difference. So how far along they are, the gestational age, the quality of the amniotic fluid. If there's meconium present, there's a potential for a pneumothorax that we might have to needle aspirate. If there's excessive fluid, as an assessment, that could mean more fluid than we're comfortable with. That could mean a TE fistula, tracheoesophageal fistula. So there are clues about the health of the baby by the quality of the amniotic fluid and how much of the amniotic fluid is. If mom's been reporting that they've had a little bit of a leak the last week or two, that could mean that maybe the baby's been exposed to an infection. If the baby's post-term, they could, the first breath of life, they have to take a deep breath and open up all their alveoli. What kind of pressure does that take to open up all their alveoli? The diaphragm has to contract. All the lungs that were closed now have to be filled with air. It usually takes minus 90 to minus 120 centimeters of water pressure. So a baby has to generate a huge pressure to open up those lungs, and that pressure can expose a baby, especially a post-term baby that's really strong and has more muscular strength. They can blow a pneumo on that first breath. It's possible. So if a baby's post-term and they have to breathe in really deeply, and maybe they don't have enough surfactant the first time, and a lot of times they'll kind of massage the baby that's born through the cervical canal. Actually is a benefit. Babies that are born by cesarean section don't get the benefit of being squeezed through the birth canal. What benefit can you think of that might help as far as surfactant's concerned? Yeah, exactly, Alicia. It redistributes surfactant around all those little alveoli so that on the first breath of life it minimizes surface tension so we can open it up under minimal amount of pressure. So if a baby's born, bless you, if a baby's born by C-section, they don't get the benefit of redistribution of surfactant, and so they have to generate more pressure. They could be at risk for pneumothorax. So it doesn't always happen, but I think being aware that that's a possible complication for a C-section. Another thing for C-sections is that babies will sometimes be diagnosed with TTN. Have you heard of that before? TTN, transient tachypnea of the newborn. So it just means that they have to breathe faster because these poor little alveoli haven't been properly surrounded by surfactant so they can open up with lower pressures. So they develop a condition called TTN that we have to watch for and make sure that they don't have any adverse complications from being born by C-section and developing TTN. So luckily, I think the research has been showing that normal vaginal births are beneficial and even though their C-sections can be convenient for moms that can schedule them out, that, you know, if they got things to do and they have to do them on Thursday so they can do something on Friday. And moms aren't like that, right?
No.
They don't have things to do. Truman, if your wife was expecting you want to do it on this day so you can go golfing the next day, right? So sometimes we get involved in the normal daily things of our life, and medicine is just it's a convenience to be able to schedule a C-section, but there are inherent risks to doing things out of the normal pathways. C-sections carry potential risks that we don't often consider, and it's invasive, and you know, you're making incisions, and there are complications involved with cesarean sections. There's no doubt about it.
So did your wife have C-section?
Not a one.
I was born by C-section.
Where and in the 70s and 80s and 90s, we grew into the medicine, and hospitals and healthcare was more of the convenience of the patient. And I think we're getting back, it seems like the pendulum's swinging back to more naturalistic types of things and homeopathic medicine, things that are better, you know, on the whole rather than for the convenience. We still do a lot of things for the convenience. We'll stop into an ER at the convenience, but go ahead, Hannah.
Just a question with like at-home births and
Yeah.
how do you feel about that? And is there a way for like a midwife to get that meconium out if that is something that ends up being present?
They may have such. Actually, my wife's, or not my wife, my daughter's husband's mother is a midwife.
Okay.
She does a lot of water births. She's very capable. She's probably delivered 2,000 or 3,000 babies in a 40-year career. She's very comfortable. But if there's a complication and you need it, I mean, she's sent babies to the ER and from the birthing center. So I feel comfortable with it. My daughter didn't want to have a baby by water birth, even though her mother-in-law and her husband was from that culture.
Yeah.
So, but she went to the hospital.
There's some hospitals that
do have them.
have water birthings, and you can do
Exactly.
it in the hospital. It's getting more popular.
It sure is, and there may be something about bringing a baby into the world with, you know, a comfortable environment that they can transition. You know, maybe there's something to that. I don't know. More research needs to be done. So my point is, though, is that children are different. We have to consider different things: the gestation, the meconium. That certain signs and symptoms, if they're post-term, if they're preterm, if they have lots of amniotic fluid, if they have a little bit of amniotic fluid, can mean things. The presentation of a baby can mean things. If they're breech presented, in other words, if their bottom's coming out first, that could, I mean, you have to readjust and reposition the baby so it comes out head first. But breech position can be a big imposition. Again, whether they're born by C-section, The condition of the placenta, extraordinarily important. Anybody know what the PO2 is? We just talked about PO2. What's the PO2 in utero for a newborn baby? In the uterus before they're born. Anybody know? Hell no. PO2. So at sea level, it's 80 to 100. Breathing room air. What is it in utero? Nope.
Dang it.
I can tell you, it's 28. So the PO2 in utero is 28. It's lower than at the high than if you were climbing on Everest, and yet they're growing at a faster rate than any other time in their whole entire life. PO2 in utero is 28. So if there's a tear in the placenta, it could limit gas exchange. You know, it could lower the PO2 from 28 to 20, and then these babies get smaller and smaller because they don't have all the nutrients that they need from blood flow. So the quality of the placenta, extraordinarily important. Whether they have a placenta previa, that's just a simple tear, a placenta previa, versus a placenta abruptio. So if I've had one in my career, I had one mom that abrupted the placenta. That means it came completely away from the wall of the uterus. And so that becomes a medical emergency. We had to do a C-section immediately to get the baby out because there was no gas exchange whatsoever. The baby did fine.
How do you do that? How does that happen? Do they not know?
Mom moved in a particular way, or it was...
Would you be able to feel that?
No, I don't think you could feel
You know
it.
what I mean? Like,
That's scary that you couldn't tell.
The infant gives signs of being stressed, so the heart rate starts going way up, and there's bloody discharge that you can tell. I wonder if the
Something's up.
placenta is abrupted.
Okay.
So if and I think this one
so many things.
there are. That's the thing with
Terrifies
medicine is that
me.
we end up knowing too much.
I know, right? You're
And
like,
it scares the hell out of us.
With the breech thing, so
Yeah.
my niece was breech,
Yeah.
but because she was breech, they did a C-section. So
Yeah.
would we better to like go in and do a C-section at that point, or
Could
try
be.
to turn them around?
Yeah, if you can't turn them around, C-section is the way to go.
Yeah.
Because, at some point you've got to make a medical judgment that you got to get the baby out or get them turned so they can come out correctly.
What would happen if you tried to bring it out?
Oh gosh,
Oh,
that's happening.
that poor mom. I
I
can't imagine.
No.
Yeah, exactly.
Just leave it in.
So at that point, it's better to make an incision and bring the baby out, and not having to go through that.
It's going to call the midwife.
But you're so right that what we end up knowing about and the problems, it's a wonder we're not all on, anti-anxiety medications.
So as a respiratory therapist, are they, with C-sections, do they always call you into a C-section?
Usually.
I was gonna say, yeah.
Usually, especially now because the risk
Yeah.
is so high that even small community hospitals in this area, Tremonton, Park City, Heber, they've all hired now respiratory therapists over the last 5 years because the high risk delivery is such. It's better to pay a respiratory therapist to be in there to do airway control rather than pay a lawsuit for something that happens.
Yeah, because I followed a respiratory therapist and there was a C-section, and so we went into that and we were the first ones to get the baby and
Yeah, absolutely. You're there,
do all
man.
this testing and stuff like that. It was intense, but
Yeah.
it was cool. It was the coolest part of it.
And you were
But
saying,
I was
Of
like, oh
course.
my gosh.
Yeah. So we're pretty highly involved in high risk deliveries.
Yeah.
We have to know something about the history, the mother's history, the amniotic fluid, presence or absence of meconium, what the gestational age is. All those things are meaningful and relevant in the assessment, so we know what to prepare for. And usually in a hospital room, there are resuscitation areas where you've got a warmer and you've got all of your equipment and
Yeah.
things are always there.
With this baby, they were worried that the blood sugar was too low. So I guess the mom became diabetic when she
Diabetic
got pregnant,
mom.
and so we had to do a blood sugar test because the baby was shaking. And
Yeah.
Anyway.
Yeah. So our role then is to create a physiologic condition. Make sure the PO2s are right. Make sure the acid base is right. Make sure the CO2 is here. Make sure the glucose and the lab chemistries are all within normal limits. And so every little thing has a particular assessment to try to make sure that they're they're in a physiologic area that they can grow and develop and progress. So if they have a poor start to that, that is incumbent upon the healthcare practitioner, the physician, the nurse, the respiratory therapist, and anybody else that's there to help to right the ship, so to speak. I mean, really, when a patient crashes or an infant comes out and they're listing on one side, we do everything we can to right the ship and make sure all the physiologic parameters are correct. Go ahead, Megan.
So you were saying that, like, in more rural hospitals, respiratory therapists are present for most
Much
of
more,
every
yeah,
delivery.
much more
And
present.
so in more of an urban hospital, are we not as involved in births? Or?
If you can identify high-risk deliveries.
Uh-huh.
So in the normal deliveries, maybe not,
Okay.
but in the high-risk deliveries, yeah,
Mhm.
definitely. They want us there to manage the airway.
Okay.
So anybody want to do neonatal?
Oh.
It's amazing. I was a neonatal therapist for quite some time in my early career, and I had 2 children that one of them that died after 18 months from prematurity. So I have a particular fondness to see the kids that are born at 35 or 34 or 33 weeks that do well. They're miracles, and I take particular joy in seeing them progress and do well, and they're off in their lives doing great things. And so
My dad was born at 26.
26.
Holy
Can you even imagine that? 26 is about the size of a Coke can.
That's
Amazing.
Especially that New Year's.
Your dad was
Yeah,
26.
that's
Like,
amazing.
how do they
I think
even,
one of my nephews.
How-
how does
He's a
everything
miracle.
work?
It's
It's
an
like
absolute
so,
miracle that
that's crazy.
Well,
and now look at you.
No,
That explains a lot of things, Kyle.
Well, my friend I was telling you about a couple weeks ago, that's my age, she was born at
I stayed
22
in there long enough.
22
weeks.
weeks.
Yeah, 22 weeks. It was the
Amazing.
youngest surviving baby in Utah at the time.
That's phenomenal.
Yeah.
So we have to know about gestational age to make a judgment about what you can expect when this baby's born, and what you're going to have to do based upon the gestational age to be ready and prepared, and to improve the quality of their life. What you do in those first few minutes could have an impact on the
When
rest
my
of that
friend was
life.
born, her dad could hold her in his hand
That's how important it is.
in one palm.
So placenta previa is a tear in the placenta. Placenta abruptio is a complete disruption of the placenta, and that's a medical emergency. There's another condition called a nuchal cord. Have you heard of that before? Nuchal, N-U-C-A-L. What is it?
It's like a trap around.
Yep, sure is. Nuchal cord times 1, times 2, times 3.
Scary.
So the more times it's more.
The last baby we wrapped around twice, but it didn't affect her at all.
Yeah. It depends on how the baby moves, and it can go around once or twice,
She had a
and
really long
cord.
Isn't it pretty common for
It is.
like 1 or 2 times?
Exactly. It's very, very common. So in the description, if it's a 1, 2, or a 3, the severity depends on how many times, basically, and how tight it is, and what the activity of the child was, and watching. Usually during labor, they're watching for any sign of stress whatsoever. Usually tachycardia. So tachycardia means hypoxemia, and so of the baby. So they'll monitor the.
They have little monitors.
Yeah,
They're all
it's like a little ultrasound that sits on her tummy, and so you can hear the heartbeat.
Usually during the whole process.
Yeah.
You're hearing
Yeah.
the baby.
Never?
No.
So if the baby has 3 times wrapped around their neck, it could cause asphyxia. How many babies are born cyanotic? All of them. They're not necessarily asphyxic until they've limited their oxygen delivery at the alveolar level. So bradycardias are particularly troubling. If a baby's born, if the mom's in active labor and they have a Brady episode, that's particularly troubling. It could mean something's happening. So they try to get them out as quickly as possible.
C-section.
Yeah, they did a C-section. So if they Brady down, you're trying to get in there to make sure you take care of the baby. And you'll talk more about apnea and cyanosis. Babies, especially if they're born less than 34 weeks, they tend to not have very good muscle tone. So we will often do assessments on newborn babies once they come right out. If mom's required any medication, sometimes if they're on narcotic medications, babies can come out depressed. So their respiratory effort's depressed and they might need a little bit of extra help. So we need to know that in the assessment of the mother to try to figure out what their depression is from. So a lot of times when babies are born, we do something called an APGAR score.
Bless you.
Bless you. APGAR is an assessment that therapists are responsible for that does a quick assessment at 1 and 5 minutes. And we give them a 0, a 1, or a 2 score. So it's in five categories. We're giving them a 0, a 1, or a 2. So the first category usually is, should I make this up? First category is an assessment of the heart rate. So heart rate is the first one. And basically, we want to know if the heart rate's greater than 100. Okay. So the fastest, easiest way to do a heart rate is to touch the umbilical cord. So they have a vessel in the umbilical cord that matches their heart rate. So we don't listen with the stethoscope, we just hold the umbilical cord near the tummy and we can get a pulse rate in the umbilical cord. That pulse rate should be greater than 100, and we don't always necessarily count it, we just get a feel for if it's higher or lower than 100. Okay, do you think you can get to that point? Where you can do an assessment, you hold on to the umbilical cord and okay, it's greater than 100. You can generally tell.
Yeah.
If it's particularly slow, then you might want to get,
Start
okay,
counting.
it's really only 92. You know. So the heart rate's the first assessment, and if it's less than 100, we give it 0. If it's if it's less than 80, we give it 0. If it's between 80 and 100, we give it 1, and if it's more than 100, we'll give it a 2. So it's a quick assessment. So an APGAR is based upon a 1 to 10 score in 5 categories, heart rate being the first. The other one is respiratory rate or effort. So usually we can tell if a baby's, if their chest is moving up and out, and we can see that they have an effort. They're moving their chest and their rib cage upwards and outwards. If it's more than about 30 times a minute, we give them a 2. If it's between 10 and 20, we might give them a 1. And if there's no effort at all, we give them a 0. So it's possible for a 22-weeker to come out with no effort whatsoever. They're not supposed to be breathing. They're not going to be breathing at 22 weeks. So they have 0 effort. The third area to do a quick assessment is the color. So how many babies are born pink?
None.
None of them. So no one ever gets a 2 for color, at least at the first minute. Okay? Every baby is given a 0 or a 1 because they're never pink at that first minute. So if they're cyanotic and blue and they stay cyanotic and blue over 1 minute, we give them 0. If they're starting to pink up a little bit, they have respiration efforts, then we give them a 1. But I've never seen any baby ever get a 2 at 1 minute because they're all born cyanotic. The next one is muscle tone. So usually what we'll do is babies that are born 40 weeks gestation, we can usually pull their arm out and away from their body. So usually it's into their core. And so if we pull their arm out, and if it just drops, that's a 0. So there's no muscle tone at all. A 22-weeker, I imagine, would have no muscle tone at all. They would just be flaccid. So you pull their arm out, and that's about what you get. So you pull their arm out, and it's flaccid. That would be a 0. If they have some tone, but they don't really pull it back, that's a 1. And if they do bring it back to their core, then you know they've got some muscle tone, and that would be a 2. The last one is irritability. So reflex or irritability. And I've seen this a couple of P-I-L-I-T-Y. I've seen it a couple of ways. Sometimes they'll put a catheter in their nose and see if the baby has a reflex and sneezes. Another time they'll flick their heel to see if they cry. So, but what they're trying to do is they're trying to initiate a reflex or irritability kind of a reaction. So usually most kids have a 1 or a 2 on that if they're born anywhere near.
Usually they like pull on the arms and they start crying then.
Yeah, exactly. So an APGAR score is a 1 to 10 rating at 1 and 5 minutes. Usually, I've seen the nurse and the therapist work together to give an APGAR score, and so it might be 5 and 7. So at 1 minute it was 5, at 5 minutes it was 7. It just means that they're getting better, they're pinking up, they're doing, as far as an assessment is concerned, they're doing much, much better. So an APGAR is a very common assessment scoring at 1 and 5 minutes to look at the viability of an infant. It's a quick assessment that allows us to determine if a baby's vigorous versus if they're not really conforming to life outside the womb. So an APGAR score. There's another scoring system called the Dubowitz scoring system. Dubowitz is more gestational age. It assesses a baby what they're capable of doing, but it assesses more for gestational age. It's a gestational assessment, not a viability assessment like an APGAR is. So every baby gets an APGAR. Some preterm babies they'll do a Dubowitz to determine developmental age, and go from there. So after a child's born, a lot of times in well baby checks, they'll compare a baby or an infant or a child to normal growth patterns. So you'll compare to the age and height of an infant born near the same time as you were, and you're comparing it to a growth curve, basically, about what percentile they tend to be grouped into. So if you're in the 20th percentile, it means that 80% of the kids are bigger or heavier than you are, your head circumference. So they do a couple of measurements and they compare it to a growth curve, and that's how they look at growth and development in kids. But growth and development in kids and child assessments depend upon the pattern of growth and how they're meeting their developmental markers throughout childhood up until the time they enter school. So kids are definitely a challenge. It starts with newborns, but babies and what's interesting about pediatrics is that kids often don't tell us what's wrong. They might be able to point if you're lucky, but kids are telling us signs and symptoms of potential problems if we can pick up on those signs. And what I mean by that is that a kid might cry or not eat or get dehydrated. They won't tell you, hey, I'm dehydrated. You'll have to pick up on signs that they haven't had a wet diaper in 4 days. Maybe they're dehydrated. So you have to pick up on subtle signs and symptoms to try to use that as an assessment to determine when a pediatric patient needs help. I've had a few students that did patient assessment projects on veterinarian veterinarians. And the thinking is that animals often don't tell their owners what's wrong with them. But if you can find out how a veterinarian does an assessment on an animal, no different than doing an assessment on a kid, right? Kids don't tell you. So in this one bachelor's project, one of my students did some interviews with a veterinarian to find out how they investigated problems and how they came to conclusions in the assessment of their animals and how that compared to a pediatrician. So you'll have complete opportunity to investigate those kinds of projects. So, any questions on the assessment of an infant or child? A little bit different than an adult. Adult just tells us, we use that information to help us to make conclusions about the care. Infants don't always tell us. We have to be perceptive. We have to rely on the parents. We have to use tact and compassion with children. And it can be quite a bit different than with adults, but it presents some challenges, but I think we can overcome it. Not many of us really do much in the way of pediatrics other than with RSV in the fall. So hopefully your clinical rotations starting in just a couple weeks. We'll have some RSV patients that you can do assessments, suction, look at their oxygenation.
I mean, hopefully there's no RSV patients, but.
Right,
That
exactly.
happens.
If there are.
Isn't that funny? We wish for the bad things to happen so we can practice and experience them. So we'll have those experiences, no doubt about it.